Hi, good evening, friends. Welcome to our channel, The Nurse. Here we are discussing about cardiovascular system, second part. Yesterday we discussed 21 questions, so we will discuss uh, from 22nd onwards. 15 questions we will discuss. 14 questions we will discuss here. So yesterday I discussed mostly about anatomy and physiology part of the cardiovascular system. In this video, we will discuss anatomy around 9 questions, anatomy and physiology 9 questions, and rest of the questions from disease condition, pathological conditions. So tomorrow we will include more questions from disease condition, that is pathological conditions, and day after tomorrow we will discuss about pharmacological conditions, pharmacological related nursing questions and answers. And we will start now. Before starting, if you are not subscribed to our channel, please subscribe. Cardiovascular system, nursing questions and answers, part 2. Cardiovascular system, part 2. So yesterday we discussed 21 questions there. So we will start from 22nd questions. And one more thing I need to explain that yesterday I in 18th question we discussed that bundle of fish can initiate electrical impulse, that is 40 to 60, but that is a mistake. So bundle of fish can initiate maximum 20 to 40 impulses only. So 40 to 60 impulses can initiated by AV nodes when SA nodes fails. So Lumina was asked that doubt there. So I was confused in yesterday's class. So please, sorry for that. So we'll start the first question. Role of renin in BP control. Angiotensin 1 to angiotensin 2. Release of aldosterone, sodium and water retention, angiotensinogen to angiotensin 1. Main role, angiotensin 1 to, it converts angiotensin 1 to angiotensin 2. Releases of aldosterone, sodium and water retention, angiotensinogen to angiotensin 1. So you need to understand what is renin, angiotensin, aldosterone mechanism well, RAA system mechanism. Then only you can answer this question. So I will check the correct answer. So most of you given option A and some of you given option D. So we'll check the correct answer. Correct answer is renin converts angiotensinogen to angiotensin 1. Renin produced by kidney that converts angiotensinogen to angiotensin 1. Renin is produced by kidney when there is a hypotension. There is decreased blood flow to kidney. That time kidney produces renin to blood. So this renin converts angiotensinogen to angiotensin 1. Angiotensin is produced by liver. This angiotensinogen converted to angiotensin by renin. Then this angiotensin 1, that is again converted into angiotensin 2. Angiotensin 1 is converted into angiotensin 2, that is helped by ACE enzymes. Angiotensin converting enzyme, that is produced from lungs, mainly from lungs. So this angiotensin converting enzyme converts angiotensin 1 to angiotensin 2. This angiotensin 2 promotes the production of aldosterone. Angiotensin 2 and aldosterone combinedly, that is helps to vasoconstriction, and aldosterone helps to reabsorption of sodium and water. So aldosterone helps to reabsorption of sodium and water, and it also, this activity increases the potassium excretion also to maintain the electrolyte imbalance. During the reabsorption of sodium and water, potassium excretion also will be high. That is renin angiotensin aldosterone mechanism, RAA mechanism, very important in every most of the government exams. It is one compulsory question from renin angiotensin aldosterone mechanism. Renin converts angiotensinogen to angiotensin 1. Renin produced from kidney, angiotensinogen produced from liver. Angiotensin 1 then converted to angiotensin 2 in the lungs with the help of angiotensin converting enzyme. Angiotensin 2 stimulates the release of aldosterone, which promotes water and sodium retention by the kidneys. This action increases blood volume and blood pressure. When reabsorption increases, the blood volume automatically increases, then BP also will increase. Next question. Extremely specific, most sensitive marker for MI. Easy question. Myoglobin, CKMB, TROP-T, TROP-I. Okay. All of you given correct answer only, that is option D, TROP-I. Extremely specific, most sensitive marker for MI, that is TROP-I. TROP-I level will increase after 3 hours. After the MI, within 3 hours, TROP-I level will increase and it will sustain for 7 days. So, first extremely and most sensitive marker is TROP-I. TROP-I has high affinity for myocardial injury. It rises within 3 hours and persists for up to 7 days. So, acute coronary artery disease, that is due to MI, we can identify with TROP-I. Normal values are with the troponin T. Normally, troponin T normal value is 0 to 0.2 nanogram per ml, and troponin I being less than 0.6 nanogram per milliliter. Nanogram, it is not milligram, very minute amount only. Thus, any rise can indicate myocardial cell damage. Next question. Endocardium is lined by. Yesterday we discussed that endocardium is lined by epithelial cells. So which kind of epithelial cells? Columnar epithelium, squamous epithelium, cuboidal epithelium, transitional epithelium. That is squamous cell epithelium. Squamous cell epithelium, that is also known as endothelial cells. That is also lined in blood vessels. Endothelial cells also lined in blood vessels, that is same cells are lined in innermost layer of the heart. Squamous cell epithelium, also known as endothelium, that lines the chamber of the heart and is continuous with the lining of arteries and veins. Next question. I think this is also easy question. Each small square in ECG strip represents 0.2 seconds, 0.12 seconds, 0.04 seconds, 0.08 seconds. 25th answer. Okay, I think this is also easy question. Correct answer, option C, that is 0.04 seconds. Smallest cell in the ECG represents 0.04 second. The normally in ECG speed, that is 25 millimeters per seconds. That is 25 millimeter equal to, that is 1 second. If speed is we kept 25 millimeter per second, means 25 millimeter, that is traveled during 1 second. So 5 mm or 5 mm means, that is this 1, 2, 3, 4, 5. 5 small cells, that makes 5 mm, that is 0.2 seconds or 200 milliseconds. 1 mm means the smallest square. 1 mm is equal to 0.04 seconds or 40 milliseconds. So 1 small square equal to 0.4 seconds, that is 1 mm. Or that also we can say 40 milliseconds. 0.04 seconds or 40 milliseconds. Each large square represents 0.2. This is a large square. This square represents 0.2 seconds or 5 millimeter. Next question. IV infusion given for patients who are unable to tolerate stress test. IV infusion given for patients who are unable to tolerate stress test. Calcium channel blockers, beta blocker, dipyridamole, theophylline derivatives. Stress test usually doing to assess how the heart blood circulation is good or not after the any activities. Correct answer is dipyridamole. That is given for those who are those patients who are unable to tolerate stress test. Stress test is also known as exercise stress test. Dipyridamole given to dilate the coronary arteries and stimulate the effects of exercises. Dipyridamole given to dilate the coronary arteries and stimulate the effect of exercises. Caffeine and theophylline products are held 12 hours before the stress test. Caffeine products or theophylline products are withheld before 12 hours. 12 hours of stress test. Same time, calcium channel blockers, beta blockers are held withheld before 24 hours. So theophylline products withheld before 12 hours, beta blockers and calcium blockers withheld before 24 hours of the stress test. The pressure within the superior, next question, the pressure within the superior vena cava and under which blood is returned to the superior vena cava and right atrium. The pressure within the superior vena cava and under which is returned to the superior vena cava and right atrium. CVP, MAP, PAWP, aortic pressure. Central venous pressure, mean arterial pressure, pulmonary artery wedge pressure, aortic pressure. So all of you know the correct answer, that is option A, central venous pressure. Central venous pressure. That is the pressure of superior vena cava, or we can indirectly assess the pressure of right atrium. Central venous pressure, normal value, that is 3 to 8 millimeter of mercury. 3 to 8 millimeter of mercury. Centimeter of water means 5 to 10 centimeter of water. Here it is 3 to 8 millimeter of mercury. Next question. After PTCA, the first indicator of graft occlusion. Reduced pedal pulse, temperature change in extremity, color change in extremity, pain. After the PTCA, the first indicator of graft occlusion. First nursing priority after femoral catheterization, if it is asked, then option A will be right. That is, you need to check the distal pulse. Here question is indicator of graft occlusion. Okay, anyway, we'll check the correct answer. First indicator of graft occlusion after percutaneous transluminal coronary angioplasty, that is pain. Pain is the first indicator of graft occlusion. It is an important question. You need to learn this answer. First indicator of graft occlusion is pain. That is cruciate pain, cruciate chest pain. That is first indicator of graft occlusions. Pain is the primary indicator of occlusion, and most commonly graft occlusion after PTCA can happen within 24 hours. So important is within 24 hours, if patient is complaining very severe pain, means that is indicator of graft occlusions. Very important question. Next question. Removal of a plaque from an artery by the use of cutting chamber on the inserted catheter or a rotating blade that pulverizes the plaque. Pulverizes means cutting into small pieces. removal of plaque from an artery by the use of cutting chamber on the inserted catheter or a rotating blade that pulverizes the plaque. Transmyocardial revascularization, arterial revascularization, CABG, arterectomy, removal of plaque from an artery by the use of cutting chamber on inserted catheter or a rotating blade that pulverizes the plaque. Direct question. Delhi एम्स में salary it will be more than 60,000. Thank you, Mukesh. I think it is direct question. Correct answer is option D, arterectomy. Arterectomy means removal of plaque from an artery by the use of cutting chamber on the inserted catheter or a rotating blade that pulverizes the plaque. Directly, arterectomy, that is removal of plaque from an artery. Other part is just for making this question little beautiful. Removal of plaque from an artery, it is known as arterectomy. Arterectomy is used to improve blood flow to the ischemic limbs in individuals with peripheral arterial disease. Arterectomy is used to improve blood flow to the ischemic limbs in individuals with peripheral arterial disease. Next question. Second most common symptoms of myocardial infarction. Second most common symptom of myocardial infarction. Need to read question twice, then only you can answer. Pain, dyspnea, edema, palpitation. Read question carefully. Okay, we'll check the correct answer here. Correct answer is dyspnea. Primary symptom of myocardial infarction, that is chest pain. Second most common symptom, that is dyspnea. Edema, palpitation, it is also seen, but it's a common symptom that include chest pain and dyspnea. Dyspnea is the second most common symptoms related to increase of oxygen need in the metabolic activities of the body during an myocardial infarction. Dyspnea is the second most common symptoms related to an increase of oxygen need in the metabolic activities of the body during myocardial infarction. The most common symptom of MI, that is chest pain, resulting from deprivation of oxygen to the heart. So first common symptom is chest pain, then dyspnea. The reason is due to lack of oxygen supply to the heart. So heart will fail to work. Then other body parts also will get less oxygen supply only. That time dyspnea will happen. Next question. Obstruction of left anterior descending artery results in. Yesterday we clearly discussed the area supplied by the left anterior descending artery. So obstruction of the left anterior descending artery results in anterior wall MI, inferior wall MI, posterior wall MI, lateral wall MI. Left coronary artery has two branches, left anterior descending artery and circumflex artery. So first I explained regarding left anterior descending artery supplied area. Anterior wall MI. Left anterior descending artery mainly supplies anterior wall of the heart and septal part of the heart. Then it descends to down. So that is the area of supply of left descending anterior descending artery. So any obstruction of the left anterior descending artery will leads to anterior wall MI. Obstruction of the left anterior descending artery may cause anterior or septal wall MI or both anterior and septal wall MI. Obstruction of circumflex artery that causes posterior wall or lateral wall MI. Obstruction of the left circumflex artery causes posterior wall or lateral MI. Obstruction of the right coronary artery which supplies SA node and AV node. Obstruction of the right coronary artery results in inferior wall MI. So I think it is clear for you. Next question. The primary prevention for reducing a female patient's risk for developing coronary heart disease is to. A primary prevention of reducing a female patient's risk of developing coronary heart disease is to avoid excessive weight gain during pregnancy, enroll in a cardiac rehabilitation program, take 81 mg of aspirin daily, take nitroglycerin at the onset of chest pain. I think all of you know primary prevention of reducing females patients' risk for developing coronary artery disease, that is avoid excessive weight gain during pregnancy. That is one of the risk factor for getting coronary artery disease in female patients. Only the risk factor, so we can prevent this weight gain during pregnancy, overweight gain. So normally during weight gain, expected weight gain, that is up to 11 kg. So more than that, it will be excess. So it will leads to high risk for coronary heart disease. A high BMI at the start of pregnancy significantly increases the risk of several diseases later in life. A high BMI at the start of pregnancy significantly increases the risk of several diseases of later in life. Risk only. However, a high weight gain during pregnancy was only significant for future overweight and obesity. So this overweight and obesity will lead to coronary artery disease. That is what it is, a risky factor. Next question. What type of cardiomyopathy is most commonly associated with the sudden death of young athletes? Dilated cardiomyopathy, restrictive cardiomyopathy, hypertrophic cardiomyopathy, all of the above. Okay, correct answer is hypertrophic cardiomyopathy. The cardiomyopathy that most commonly associated with the sudden death of young athletes, that is hypertrophic cardiomyopathy. Hereditary hypertrophic cardiomyopathy is due to autosomal dominant mutation in beta myosin heavy chain, but in athletes it will be due to the excessive exercise. So that time that is left ventricle will be hypertrophied because of the increased need of contractions or strong contraction. That time that myocardium of the left ventricle become hypertrophied in athletes. For hereditary reason, that is autosomal dominant mutation in beta myosin heavy chain, it causes massive hypertrophy of the left ventricle, which results in diastolic dysfunction and subaortic stenosis. Thus, there is an increased risk for ventricular arrhythmias, which is common cause of sudden death in young athletes. It is confusing type explanation. Which is the primary consideration when preparing to administer thrombolytic therapy to a patient who is experiencing acute myocardial infarction? Which is the primary consideration when preparing to administer thrombolytic therapy to a patient who is experiencing an acute myocardial infarction? History of heart disease, sensitivity to aspirin, size and location of the MI, time since onset of symptoms. Clue is door to needle. So we'll check the correct answer. Correct answer is time since onset of symptoms. The primary consideration when administer thrombolytic therapy to a patient who is experiencing an acute myocardial infarction, that is time since onset of symptoms. That is door to needle time. Door to needle time means the time of onset of symptoms to starting of IV thrombolytic therapy. That time duration is known as door to needle time. The door to needle time should be within 24 hours. So after 24 hours, thrombolytic therapy is not effective. So always door to needle time should be within 24 hours. 24 hours of onset of symptoms. During ST elevation myocardial infarction, fibrinolytic therapy or thrombolytic therapy must be instituted within 24 hours of symptoms of onset. That is what door to needle time. After this time frame, fibrinolytic therapy or thrombolytic therapy is contraindicated and likely will not be effective. So after 24 hours, there is no effect on thrombolytic therapy. So that is door to needle time is important. Okay, that is about today's video. 14 questions we discussed here. That is mainly from anatomy and physiology from the cardiovascular system, and some of the questions from pathological conditions related to cardiovascular systems. Tomorrow we will discuss more questions from pathological conditions related to cardiovascular system. So till that time, goodbye. So we will watch tomorrow 9 o'clock.